Okay. Good morning, everybody. There's a really, really nice hum in this room. It's really good and lots of quite excited chatter. So thank you very much for joining us today. Thank you for giving up a day of your time. My name's Olivia Butterworth. I think I've got the best job title in NHS England. I'm Head of Public Voice. That does not mean I am the public's voice. It means that my team's responsibilities are about making sure that the public have a voice. So we act as a conduit, we act as an amplifier, we act as an advocate to make sure that people have a say and are able to influence. This is our NHS Citizen project, framework. I don't know what we call it, but this comes from when Tim Kelsey first came into post as National Director for Patients and Information, his desire to make sure that there is genuine accountability for the Board of NHS England to citizens throughout England. This is a process of design. It's a work in the making. We're creating it. You're creating it. So by being here today, you're part of the next iteration of what this might look like. We have no blueprint, and that's absolutely genuine. We don't have one in the cupboard that we'll pull out and go, ta-da, here it is. This is about making it together and co-creating it together. Before I witter on any more, I want to introduce Anthony Zakharevsky, Catherine Howe, Nagina Javed, who's very busy tweeting, Clive Mitchell, Leslie Brissett, who's now in the room. Come in the room, Leslie. And Rosie Farah, who's actually my daughter, so she's going to be good. She's going to be our social reporter for the day. So we're your NHS Citizen team, if you like. We come from different organisations. I work at NHS England. We have Public Eye, the Democratic Society, Involve, and the Tavistock Institutes. Not the Tavistock and Portman, who are also in this building today. Quite interesting. And we're here to facilitate. We're here to help the conversation. We're here to try and listen and to try and think about what this might look like as we move forward. We are webcasting this, so these little cameras around the room mean that we are live on the big World Wide Web. So if you want to say hello to people who might be watching. And we're also tweeting. So this is about trying to make sure that we broaden the conversation, that we bring people into the room who might not be able to get out of the house, who might be in a different part of the country, but that we have a genuine and open conversation. It's a bit strange and it's a new way of working for most of us, I have to say. And there's not that many of us in the room, but there's quite a lot. So moving around is quite difficult. So if I can ask you to make sure you keep bags and stuff tucked away or at the sides of the room, that'd be really helpful. And I would like to start by just going around and for people to say who's in the room. We need to use the microphones. I know you can hear me. I know that it's not about amplifying the noise in the room. It's about people out there being able to hear as well. So could we start by introducing our speech-to-text reporters, just to embarrass you?
I can't do both together.
Sorry.
I'm Susie Romeo, one of the speech-to-text reporters today.
Thank you, Susie. Sorry.
I'm Morella, one of the speech-to-text reporters today.
Thank you very much.
I'm Diane Silcott from Living Options, Devon.
Margaret Wollacott, Patient Participation Group, Oakhampton.
Derek Wollacott, West Stockman Friends and Neighbours Association.
Thank you.
Frances Newell, NHS England Public Voice Team.
I'm Christine Teller, I'm the Citizen Commissioner attached to the South West Clinical Senate.
I'm Malcolm Watson, I'm a member of South Gloss Health Watch.
I'm Bev Anderson, Tenant Participation at East Devon District Council.
I'm Neil Chambers, Public Lead for Involvement at NHS Kernow.
Thank you.
Jennifer Bate for the British Red Cross.
I'm Susie Taylor, Area Manager for the British Heart Foundation.
Caroline Harris, Exeter Health Watch Champion.
Thank you.
Karen Nolan, Devon Voluntary Action.
Kate Cresswell, National Kidney Federation.
Mike Ritson, Patient Rep.
Jenny Bowyer-Spicer, New Devon Clinical Commissioning Group PALS Manager.
Scarlett Curtis, Patient Engagement Officer for South Devon and Torbay CCG.
Jonathan Drew, Health Watch Torbay.
Good morning, Francesco Palmer, Citizen. Cliff Puddy, Somerset.
Thank you, Cliff.
James Buist from Healthwatch Cornwall.
Sarah Coburn, South Western Ambulance Service.
Deb Slate, postgraduate student at Bournemouth University.
Thank you.
Steve Edwards, Consultation Engagement for Devon County Council.
Caroline Lee, Partnership Officer, Healthwatch Devon.
Bob Buskin, Devon Senior Voice, but also East Devon District Council invited me here.
Brilliant, thank you. Oh, sorry.
This one.
Jane Smallcombe, South West Forum.
Louise Fowler, NHS Improving Quality, Experience of Care Team.
James Dyer, NHS User.
John Amersford, Devon County Council, Strategic Engagement.
So, well done, the South West. I think this is probably the most diverse group of people we've had from different places and different organisations and different interests in one room. We've managed to get people with a local government interest, which is absolutely fantastic, and an ambulance service. Thank you. It's really important because actually some of the conversations we're going to talk about today are about what the boundaries of this are. So if we approach this from a no wrong door attitude to making sure people have a route into having a voice, how does that work when you have to have some boundaries to make it relatively manageable? I'm not going to say any more. I'm going to leave it to Catherine and Anthony to introduce what this model framework as we've got it so far looks like. Is that okay?
So just very quickly before we start, first to the wide world watching out there. Sorry, I'll step away from the sort of sight line of the screen. First to the wide world watching out there. Do tweet on the NHS Citizen hashtag any thoughts, comments or questions you want brought into the room. And Clive will be monitoring Twitter, as will Nagina. And so we'll make sure those conversations online are part of the conversation in the room today. Second thing to say is do speak up from the floor, but please do wait for a mic to come so that we can make sure it is a really properly joined up online and offline conversation. I'm going to hand over to Catherine to talk people through the NHS Citizen model for people who are coming new to it, and there'll be plenty of chance to ask questions at the end of this section, but if something really urgent comes up in the middle, do pipe up.
Brilliant. I'm mic'd up, actually. Okay, so, yes. Pardon? Housekeeping. Good, very good point. So, housekeeping, the exits are there and there, there and there, is that the assembly point is just on the other side of the road. And you can also get to it from there. There's no fire drills planned. I'm looking at Nagina because she knows all of this stuff. There's no fire drills planned, and the loos are just there, and there's another one just there. Is there any bit of housekeeping I've forgotten for anybody? And we're feeding you at lunchtime. And if anybody wants a cup of tea, then go and get it. And switch your phones to silent. Thank you. But keep them on because I want you all tweeting, obviously. So is that okay? Right, have I forgotten anything else? Yes, I'm sure you feel very confident now in the whole enterprise. You've had to be reminded of that. I'm going to step. If I stand there, then I'm not in your way. Is that better? Okay. So is that okay with you? Yeah, as long as I can see you. Okay. All right. Yeah. Okay, what I'm going to do is I'm going to try and explain to you the NHS Citizen model as it exists right now. As Olivia says, we're in a design process, which means that these sessions are very much about examining the whole thing, getting comments from people, but also working on specific issues within the model. So we'll talk about we've got some very particular questions for you guys. This is the second iteration of the model. What we did is we had one phase of work that took us basically through last year and ended at the Expo event in March. We've just rewritten the design document, which is the thing I'm afraid we failed to print out. If anybody needs a printed copy, we will send it to you, so sorry about that. But that second version is what we're going to be working with and working on, taking us through probably till September. So NHS Citizen basically comes in 4 parts. At the outer layer, and what's quite interesting, we all come from quite different perspectives, so you're getting the Catherine Howe emphasis on this. So the outer layer is something called Discover. Now, the point of Discover is to connect together the conversations which are already going on, which we know that there are some really fantastic quality conversations going on already, to provide a point of entry which is welcoming and understandable to people, and also to start to turn that into data and information that can be used in a decision-making process. So that's quite important. Was one of the reasons that we're designing this as being digital by default is the fact that we want to be using new technologies to get the best out of the information that we have. And then what we're going to be doing is we're going to have people whose responsibility it is, we think, to bring the offline conversation into that online space. So what Rosie's doing today, and Nagina and Clive, with their social reporting, so they're capturing what's physically happening here, putting it online. The webcast does the same thing. Digital by default doesn't mean we just work online, but what it means is everything gets captured digitally at some point. So firstly, it's more open and accessible, but also that we can start to learn from it more effectively. Now, what then happens in Discover? Discover we see as a really nice hum of conversation, of connected conversations. And some conversations will stay in Discover because actually it'll be about helping each other. So, so Michael was showing me a really good example of a leaflet they've been working on, something they've been doing with NHS Choices. It's a really good idea. Discover should be a way of sharing good ideas like that and sharing best practice because it connects people together more effectively. That's our aspiration for it. But sometimes you want to raise something, and we're calling it, you want to raise a flag, which is, this is an issue that needs more in-depth conversation, or this is an idea that really needs looking at properly. And what we do then is we move it from Discover into something called Gather. And Gather is a space which is about creating evidence and doing that in-depth deliberation work, which is actually, that was an idea. What do we need to know about that idea in order to decide what we want to do with it, whether or not it's a good idea, what are the boundaries of that idea? And so again, something may stay in Gather because actually sometimes just giving something a better looking at and creating that evidence base is enough. And one of the things we think is important about creating that evidence base is finding a way of connecting the different kinds of evidence that we know make up a decision. So one of the things which we think is a reason why patient voice isn't as effectively listened to as it should be is it's very difficult to take patient opinion and weigh it against something like clinical evidence. Is that, it's something that people struggle with. And the point of Gather is to try and balance out those different evidence types. For some issues, though, one of the questions is it the most important issues or is it the most complicated issues? But whatever it is, some issues will be best dealt with in front of the NHS England board and at the Assembly meeting, which we expect to happen twice a year. I'm kind of now freaked out that you stopped. Oh, no, you're quiet, though. Sorry. So the Assembly meeting is an opportunity to stop the system and to look at issues which have come out of Gather through Discover and put them in front of the board of NHS England. And that Assembly meeting is both an opportunity for NHS Citizen to set the agenda for the board, but it's also an opportunity for the system of the NHS Citizen to hold the board of NHS England to account. So it's got different functions. We also hope that it would be a way of fast-tracking a good idea from the edge of the system, from the conversations that you're having, right in front of the decision-makers. So there's lots of different functions. And obviously, some of the critical questions about the Assembly meeting are going to be who's going to be there? How is the agenda formed? How do you make sure that that meeting feels binding to the Board of NHS England so that they actually feel that they have to listen to it? Which is their intention, but that's not actually going to be, how do we mandate that? And then ideas that come from the Assembly, everything flows back because it's a connected system. So once an issue has hit NHS Citizen, the idea is it wouldn't be lost. Now, the last bit of the system is the bit which is, we think, probably the most critical, and we're calling that human relations. Because we can do the best design in the world, But if we don't get the behaviours right, and if we don't help NHS England listen to what it's hearing from citizens, then all of this is pointless and it's just another clever exercise. So the bit that surrounds all of that technical design stuff that I'm talking about is human relations. It is a culture and a behaviour change which says that actually this participation is essential to good decision making in the NHS. So that's where we've got to with it. There's a lot more detail in the diagram, and I'm just going to stop briefly and see whether or not, if that's okay with everyone. Oh, brilliant. That's the picture and everything. Has anybody got any questions? Did that make sense? Francesco. Yeah, can you wait? Do you mind waiting for the microphone? Sorry.
No, I can speak loud enough.
It's for the people outside the room.
Thank you.
It's for your internet audience.
It's only an observation to something that you said earlier on. Now, I can remember on the 4 occasions I've sat with NICE on their guidance development groups. In terms of knowledge, skills and experience, I had to have the prerequisite skills. So you mentioned about clinical evidence. Yeah. I think when patient and public easy read publications are made, it's graded evidence as good as it can be. So I don't think it's disputable unless somebody can trump NICE in terms of what that guidance might be, whether it's ST elevation of myocardial infarction or treatment for strokes and TA. So I'm not too sure that we need to question that because the team has been gathered because of their particular expertise. And I'm not too sure what you were talking about, the clinical evidence, because to me, that's what works and that's what all providers of services are actually being tasked with their commissioners to ensure that all technological appraisals and other guidance that's been published has actually been undertaken. So if I misunderstood, I apologise.
No, it's almost certainly I didn't explain it right. So I'm a social scientist, I'm a sociologist, and often social science qualitative data, it fares very badly when compared to quantitative data. So just as simple as that is that often, sort of big studies with large numbers in it will trump stuff which is much more experiential in terms of data, despite the fact they're both valid evidence types. And one of the things we're keen to do, and the issue there is that a lot of the information that you get back from patient participation will be qualitative. It'll be people's lived experiences. And it's quite difficult to weigh that against a big clinical study. And we're looking at how can that be done better. Anthony will almost certainly be wanting to jump in on that because this is his bag.
Hello, I'm Caroline from Healthwatch Devon. I've actually been looking at Bradshaw's concept of need because that's quite a useful typology when looking at quantitative data and normative and comparative stuff, which is what that data tends to be, and felt and expressed need, which is stuff that you observe and stuff that people tell you. And there is a way that you could do that quite simply and accessibly using that typology, which is recognised and used throughout, as you'll know. So I think for me, it's frustrating to hear, it's such a difficult job. I just want to get on with it and do it and get something that works for people. And there are ways of doing it, You're a social scientist, we can do this.
I think that frustration is why we think that the human relations bit is actually the most important, the critical thing here, because actually there isn't a great deal. I mean, there's some rocket science, a little bit of rocket science in some of the tech we want to use, but this is not rocket science. It is that a lot of these are known things, and so there's a good question, and Leslie's really good at asking the question which is in the room, which is why isn't this just happening? And that's one of the questions we have as well.
I graduated in '96, and the idea of what is more valid data, whether it's numbers or people's experience, that's not a new academic debate.
Not at all.
I think we should really just get on with it.
No, I agree.
I take on board the point that Frank made about the best numerical evidence not being questionable. That's true. But the question is often not whether or not we go with the numerical evidence, but whether that's the best thing by which we judge. And it's only one of the factors. You can't quarrel with judgments, for example, with NICE about whether it works or not, but you can certainly quarrel with whether or not their decision about the fact that it works and it's not going to be used is the right decision. And that's where Joe Public comes in. And it's very, very difficult to make decisions which are rational and not emotional. Because if we, almost all of us will have some degree of clinical emotional baggage, our own particular vested interests, and trying to always bear in mind what is generally the best for the greatest number of people is very, very difficult.
And that is you answered the point much better than I did. Yeah, that's exactly it. And so with the gather space, that's exactly the kind of challenge, which is so that when you bring something in front of the board of NHS England, is actually that you have you've had a really good deliberation about those kind of questions to give them confidence that they are genuinely listening to patients. Yeah. Sally?
Hi, Sally from the CCG. Just wanted to pick up on this gentleman's point about the emotional and clinical baggage and the difficulties that provides us with in terms of making rational decisions. I think sometimes we forget that one of the more useful exercises we can do is to work with people to set the criteria by which we prioritise rather than setting the priorities with them, because by working on the priorities, the criteria we use to prioritise rather than the issue at hand, you can actually divorce some of that emotional and clinical baggage because it's more of an academic exercise. Do we commission for the most people or the most needy people or whatever, rather than do we get this drug or do we have that treatment, is actually a really useful exercise but a really difficult one to do.
Yeah, it's a really good point. Got another?
Yes, Christine Teller. I'd like to ask if CCGs actually, because I think they're key actually in this very point, and I think it's a crucial point at which the citizen, the patient, member of the public can actually get involved and be quite influential. And I know Bristol, where I come from, that the CCG is now starting to develop that. In fact, I had a conversation with someone yesterday from the CCG about how the patient can become involved. And citizen can become involved. I'm interested to hear if there's anyone from the rest of the South West with CCG knowledge can tell me whether that's happening across the South West. I'm not aware whether it is or whether it's a requirement indeed for that to happen.
Do you want to?
I think other colleagues from New Devon will either pick me up on this or agree. I think it's an aspiration for us in New Devon. I don't think we've achieved it yet.
So any other questions about the whole thing? Like in that kind of, sort of, which I've done, feel like I've done it in the middle of the room, acted it out. Any other questions about that?
How are you Diane Silcott from Living Options. I wonder how you're going to get this across to the public. Joe Public sees yet another layer, another quango, another lot of money going in a different way. And for those of us who are working with, interfacing with people, engaging with people, the constant argument coming back to us is they've moved the goalposts again.
So one of the things that we've been we think is a real priority as a team trying to do the design is that when we get to the end of the process, people should see that this is a useful extra thing rather than it's if we're reinventing something that's already there, then we think we failed. So we're not imagining that sort of like point of contact that already exists will necessarily change. What we're hoping, though, is that this becomes a way of connecting the contact which is already happening to the bigger conversation that's happening. So this is, in some ways, it could be almost invisible in the front line, because actually it's about connecting things that are already happening together more effectively. Now, We do think, though, that one of the points of entry should be, so something like at NHS Choices, where you have the opportunity where, do you want to behave like a customer or a patient, or do you want to behave like a citizen? We'd like NHS Citizen to be a choice that's offered at that point. But in terms of people getting, sort of participation fatigue, is that we would hope that we're connecting to the person who is connected to a network, not necessarily, we're not expecting to speak to everybody. We're expecting to speak to people like you who are connected into bigger networks. And that if we can keep it at that level, then we think that there's a lot of additional benefit, which we don't think there's a benefit of our ambition being we have to reach everybody in the UK. That's a ridiculous ambition. We're about how do we network the networks together, because the networks, there's already great groups out there. Does that answer your question?
I think the only thing I would add on to that is my mantra, that I don't think we're designing an organisation. I think we're designing a way of working. And I think that's really important, because people have defaulted to thinking of this as a new organisation, as a new body, as a new Quango. I don't believe it is. I believe it's a way of working, and I think that's why the human relations work is so important, because if we were just doing this, surely we wouldn't need to be here. But what is it that stops people hearing voices? What is it that stops people being able to engage in a way that has impact?
Any other questions? And then just in terms of kind of like Julius Caesar, thumbs up, thumbs down, is what you're hearing, does it make sense to you? Are you happy that you've given up a day of your time to think about this a little bit more?
As Joe Blokes from the public, probably the only person, sorry.
As Joe Boggs from the public, don't have a clue. I
Really?
mean, what are you saying, that if I have a problem when I go to the hospital, then I speak to you guys and then you take that to them? Or is there, if there's a lot of us who've got a problem, then you take it to them? I mean, does that not happen already? Because if that doesn't happen, why? Am I just being a bit stupid? Sorry.
No, you're definitely not being stupid. You're definitely not being stupid. Is that so? There, if you think, we think that there are people with different levels of knowledge about how the NHS works, obviously. So sort of Joe, sort of bloke public, is that, you probably have very, very infrequent contact maybe with the NHS, or, sort of it may be routine, and you probably, a lot of people just don't have a problem with it.
More than you think.
Don't have.
No, me.
Yeah.
With the NHS, quite a lot actually.
Yeah. So where you've either got people with infrequent contact, you've got people who just it just works for them, they've got no particular desire to get more involved. Then you've got people who actually do want to be involved and who are interested in decision making, interested in that kind of stuff. There are probably different points of entry for all of those people. So for people who just occasionally use the service, we would hope that over time they would know that NHS Citizen is a way of working that means that if they did have a concern, they would be listened to. So they just be aware that it's there in the background. And we're talking, sort of 5 years in the future, it would just be there. At the point at which they're going, actually, I've got some questions here, the point at which you go to something like NHS Choices, you'd have the opportunity to say, there is a conversation, you've just asked this question. There's a conversation going on about that issue here. You could be invited into the conversation. Or you'd already be engaged in a patient group, or you'd be engaged through one of the many means that are in this room, and actually then your participation would be sucked up through that.
So, NHS Citizen, sorry.
Okay.
Correct me if I'm wrong. So you're saying NHS Citizens is effectively like NHS social media, in the fact that it's there, it's people who want to talk, can talk.
Yeah.
No, that's a good idea.
So that's but that's So what it is. So what we're really trying to do is that social media effect of conversations being connected and being quite quick and being very open and transparent. We want to try and push that kind of behaviour and effect into the offline space as well. So the way in which social media naturally works. That's a really good way of describing it.
Cool.
Good question. Leslie. Oh, Leslie, and then back here.
It was partly a question to the only person, well, there were two people who said they were citizens or people from the town. One of them just said this question about what is it all about. I think there's something about what your motivation is that made you choose to come today that could be quite useful in unlocking something. So maybe we can go back and you can tell us a bit about what made you decide to come.
Good question.
But the other thing I wanted to say was about power. And part of the idea about this NHS Citizen as a way of working, as Olivia said, was that the board of NHS England said that they want to communicate with the public, with citizens. And so this was about putting a process in place for them where they can say, we are legitimately talking to people about issues that is significant for a significant number of people in the country. So the idea is that we're cascading messages up that are of significance across the board, that we're not just talking about a few people with a particular interest in a particular part of the country. So it's a conversation piece as a whole.
I've just spoken to my colleague next door, and we've both come up with the same question. How does Healthwatch fit into this? Because surely Healthwatch England has a very similar agenda, and I, like my fellow citizen, frankly, do not understand this process at all. And certainly it's taken me a year to get my head around Healthwatch.
Yeah.
How does this differ? Healthwatch has its own representative channels through citizens' assemblies and fora and that sort of thing. I just don't understand why there is this need for duplication, triplication of mechanisms of communication.
So I'm going to let Healthwatch be Healthwatch. So Healthwatch is going to answer that question itself.
I don't think I can answer the question. I sort of agree with you. I mean, I'm representing Healthwatch Cornwall. We get in just over 250 patient experience comments a month at the moment from people that use health and social care experiences. We are then able to use that information to influence Kernow Clinical Commissioning Group if needed. Sorry, is this on? Can you hear? Is that better? Yep, sorry about that. So we can use that information to influence the KCCG, the Kernow Clinical Commissioning Group, if need be. If that information needs to be escalated to Healthwatch England, then we can do that with that information as well. And Healthwatch England then can use that information to influence NHS England, yeah? So how do we then, Healthwatch, all the Healthwatchers, all 152 Healthwatchers across the country, feed into that? Where's our place? Is there a need for a Healthwatch if...
Okay, so I'm going to have a go at this. The rest of the team, you feel free to jump in. So the first thing is that we don't want to be duplicating what Healthwatch are doing. What we'd like to do is to work out how do we include Healthwatch in that Discover system. So if Discover is all about connecting together conversations which are already happening, Healthwatch is a big conversation which is already happening, and that's why one of the things we want to talk about today is those boundaries between where does NHS Citizen need to end and where does Healthwatch need to start, what's the boundary between those organisations. So we're not talking about duplicating something that's already happening, but Healthwatch is a much more local, and that's a great thing, is a local infrastructure, whereas the board of NHS England needs something which is going to operate for them nationally, because it is about the board. Our scope is the board of NHS England wanting to listen more effectively directly to patients. So that's the scope of what we're trying to achieve. And what Healthwatch is trying to achieve is something slightly different around local commissioning. So it influences the national agenda, but it's got a slightly different intent and a slightly different audience.
That's not the limitation of...
Hang on. Microphone. Sorry.
Yes, that's right, in that Healthwatch does have a local influence, but Healthwatch itself, independent of Healthwatch England, has other channels of representation up through, for example, NHS South West and the various organisations of that, which are delegated committees, whatever, organisations, the delegates being Healthwatch representatives, so that there are more than one channel up for Healthwatch, and that's why I say triplicating, because there is via Healthwatch England, there is via things like the regional assemblies and such like, and the clinical assemblies, and now there's this. And I'm not sure where the difference lies between all three of those.
So firstly, this doesn't exist yet. So which is why we're here wanting to have a conversation exactly about these kinds of issues, which is, is what are the boundaries of NHS Citizen, should it come to existence? So this doesn't exist. This isn't something we've done. We're here to ask people their opinion about these kind of questions. And the point of today's session, because we've got really great diversity of organisations here, is that we want to talk about this particular question. So we're going to go into this in a bit more detail. You had a point over there. Oh, do you want to go first? Because you've spoken already. There and then there.
I just wanted to say, is this something, from the ambulance service, from our point of view, we cover 1/5 of the landmass of England. So we're a huge geographical area. Now, within our scope, we have numerous CCGs, numerous acute hospitals, numerous MIUs, walk-in centres, every other kind of organisation. Then you've got the GPs, and every other kind of mental health and obscure provider I'm going to forget to mention. Now, I'm in post, but that might change in 12 months. Yeah. And then another organisation is going to dissolve and become a new one. And for me, is this about connecting those NHS voices, those pockets of people, those people who've got experience, patient experience responsibilities, and tapping in across the network where we couldn't hope to do it on our own, to tap into all those different bodies and, like you say, sharing best practice. So there's actually a consistent message in the NHS for the South West, for Devon, for Cornwall, for, as far up as Bristol. And that's a part of what this model is going to help us achieve, is a consistent message going back and forth.
There's two, exactly. Is that this is almost like a connective piece of infrastructure, is how we imagine it, which connects together stuff, that exactly the kind of environment you're discussing. And also, and I think you've also brought out another point, which is when we've been doing some work sort of mapping local systems. And what's really obvious is that you've got institutions which connect in a formal institutional kind of sense, and then you've got some really critical individuals who hold bits of who appear in different organisations, and they spread themselves, they connect a lot of stuff together. These significant individuals don't get captured in any other way at the moment. So you know that this is the person who actually, if you invite them to the meeting, then they'll take the news to someone else. But we don't actually work with them effectively at the moment. We're trying to work out how we can do that better as well. So those people who hold so much of the knowledge, we want to work with them and acknowledge them as part of the system.
I was just going to say something around sort of being aware of networks. Yeah. That is what Healthwatch does. We promote and support involvement. We're not a board. We don't make decisions about commissioning. We use that information that we gather, and we make sure that systems and processes are in place in other organisations to enable that involvement to go on. That's the difference. We're here to influence an involvement culture as well as use intelligence to lead the way forward for patient and public involvement and provide that link with the public that you don't have, because we do work on the ground. I mean, in Devon, we've got people in every town that have something to do with Healthwatch. So that's our function within this, is to promote and support the good practice and to support people to have their voice heard. That's what we're here for.
Yeah, and that's why we wanted to get to Healthwatch people. This is why we need to talk to Healthwatch about this boundary question. You'd already do a lot. What are the boundaries of that? How can it work better?
As you say, we're already producing the information. It's just getting it to the out there.
So if you go,
can we just come back to James to answer Leslie's question about what brought you here?
I come here because, as a trade union member, I come here with a fear that our NHS, that me and everybody else owns, is already being sold. That's going into private hands, and I wanted to find out what you guys were going to say, and that's why I'm here, because I fear for healthcare for all within the UK. I fear for anybody who, at the moment can't even afford to feed their families. So I came here to find out what was going on, and if there's ways that real people can speak up for their NHS, then I think that should be applauded, really.
Yeah.
I just wanted to pick that point up because it's really important in trying to understand. So on the Healthwatch NHS Citizen point, I think we've kind of gone over the point a couple of times that you can't really draw a firm line on the map. Healthwatch needs to support NHS Citizen, NHS Citizen needs to support Healthwatch, and all of the other patient and public involvement initiatives that are out there. But the most important thing that you said there was, I'm concerned about the NHS in general. And I think that the distinction I would draw between the centre of Healthwatch and the centre of NHS Citizen, even though there's a lot of overlap on the margins, is that the centre of Healthwatch is a consumer body. It's about your experiences of health. Whereas NHS Citizen is a democracy body, from my perspective as running a democratic society, and it's about your common ownership of the NHS as a citizen. And so sometimes there's a lot of overlap in that, because most people who are citizens are also consumers of health services, but sometimes there isn't. And I think the gather space here is designed to draw out the broader citizen-focused conversation, rather than necessarily that this was my experience of the health service, which is what Healthwatch's core business is.
And that's proof of what happens when you listen to the citizen voice.
Yeah. Let me go there and then... Yeah.
Sorry, one last thing, because, I agree exactly with you. And the reality is that everybody cares about their NHS, but not everybody understands the way of writing a letter to their local MP, which is 2014, So if we can make it so that people can tweet you or can email you to a relevant body, which will be taken up, then that's fantastic, because we have to do something, and that's why I'm here.
I apologise to everybody else here. I got a bit late, so I might be asking a question that was answered before I arrived. As I understand it from what I've heard so far, NHS Citizen is a mechanism and a way of working that allows all the stuff that I might find out from listening to patients, all the stuff that Healthwatch finds out by listening to patients, all the stuff that patient opinion, NHS choices, all of that can be looked at for national issues rather than local issues. Have I got?
No, you're spot on. And I suppose there's so the Discover space is my space, because that's the bit I'm working on most. And in that we're going to be doing some things. So for instance, we will want to know that everybody is opted in to participate in that kind of way. So it's not surveillance, it's just kind of actually, it's like everybody knows that they've put their comments forward to NHS Citizen. And obviously everything that we bring together to get like that would be then made available to anybody who'd contributed. So everybody in the system can see, we'll be managing people's privacy, obviously, but in terms of some of those kind of like some of the data that comes out, that would be available to you as a CCG as well as available to NHS England.
But I'm also saying that our information at the CCG level, is that going into it as well?
If you choose to give it to it.
Okay. So, for instance, if I'm working in a CCG and I've worked with people and I've worked with Healthwatch throughout the year, and at the end of the year or at any point in the year, we identify a range of themes. I mean, I've worked in engagement for more years than I care to remember, and there are still the top 3 issues that people talk to us about, and they come up year after year, and it's give me information, communicate with me effectively, and do something about transition points between services. They are the top 3 and have been for over a decade. Would it be the role of NHS England, because I would like to bet my bottom dollar that other areas have exactly the same top 3, is that a role for NHS England and NHS Citizen to pick up and say, this is a thing we're seeing repeated across the country in every single area, and we as NHS Citizen need to tell the board at NHS England that they have to do something about it? Is that how...
Perfect. Yeah, exactly.
Okay.
Yeah. She's got it. Yeah, no, that's exactly it. So at Expo, we ran a system test, where we asked people to put forward issues that they thought were important in the gather space. So we mocked up the gather space and we did all of that. and accessible information was one of the things that came across. It wasn't what the board members were expecting to talk about, but through that process, it was very clear that accessible information was an issue across a huge number of different groups. Had some people from change.org who spoke brilliantly for it in the Assembly, and that was taken away by the board members as an action. And that's exactly what we're talking about. This stuff that actually niggles away and is consistently an issue sometimes fails to get in front of those decision makers, and this is a mechanism for making sure that that happens. So it's a really good way of describing it.
Catherine, I've got a couple of tweets in from the Twitter sphere to feed into the discussion here today.
Hello, Twitter sphere.
One subject has already been alluded to. Somebody who's called NHS Rocks tweeted that there's only one person, in fact I think it's probably two, who've identified themselves as citizens in the room. If I can partially answer that, but Catherine might have something she'd like to say as well. Two things to say, I suppose. One is we're all citizens here, so even though we're from organisations. But also, a lot of the organisations here can actually, as we've just been discussing, can reach other citizens and can connect to other citizens. So that might be part of the answer to that point. And also, Julia Girona tweets, it's great to think about how we should design systems or organisations, but will we reach a perfect design? And again, if I can partially answer that, I suppose in one sense, this will never be perfect. This year of design we're undertaking with colleagues, stakeholders and citizens is about designing something that we think will work. But even when it's up and running, if it gets up and running, our vision, if you like, for NHS Citizen is that it will be very highly reflective. It will be regularly checking to see if it's working, if it's the right format, if it's effective. So there won't be a perfect design. It will be constantly iterated. Yeah.
It's like a 21st century myth, the idea that you finish anything, is that everything needs to be constantly tested and improved and iterated. Yeah.
Can we just do
yep.
more? I have absolutely no quarrel at all with the ethos. I mean, I come here with a passionate belief in patients and users having a voice, and I think everything I'm doing in my life at the moment is probably much is sort of geared towards that and that passion. Reflecting really on what James was saying, I have also an equally passionate belief in the NHS and how it actually so far just, I have to say, manages to sort of level out the terrible inequalities which exist, that people who are very poor, who live in the margins, can have access to a free NHS. And I want that to continue, because I think if we go any further down the line of private vagaries of the government decisions, seems to render any project, frankly, potentially powerless. And that really does concern me hugely, that however much of a voice we have, how strongly is it being heard in the corridors of Whitehall or government? And as I said, I don't want to get hugely political today, although I could. But I actually think that we're also having a government here who's turned the NHS upside down, frankly, since last April in particular, but planning to do that since 2010, who actually didn't come into power with a mandate. So there's a whole real problem I have about how powerful can we be. Either as individuals, as citizens, as affiliated to organisations, or the NHS staff members itself. I just want to make that point, because I cannot argue at all with the ethos and the values that are being expressed in general here. But I do have a real problem about how we seem to be bashed around without seemingly no influence with the political, as I say, the political vagaries and its doings and decision making.
It's a really good point. I'm going to. The gentleman over here was waiting to come in. Is that I speaking personally, is that I think it's important to try and never underestimate, sort of what one passionately committed individual can do. If we can collect together a lot of passionately connected, passionate individuals, then there are amazing things could happen. So I think you've got to travel in hope.
Well, I generally am optimistic, I have to say, but I also have certain cynicism.
I have a lot of questions about I'm a stroke rep for Healthwatch, and I get a lot of complaints about the individual care after strokes, and we've put it through to the Citizens Council, and we put it through our CCGs, and we're still getting the same answers. Well, it depends on where you're to, which is postcode lottery again, isn't it? And if you're close to a town, then yes, you'll get a lot of... But Somerset is quite widespread, and people in the country just can't get that same sort of treatment. But what can we do about it? What can we get to those people?
Yeah, it's a good point.
I was going to say, there's an interesting point in that about the future of the NHS, and actually we've got an NHS that's modelled on what we had and the society we lived in 1948 when it was created. And that was built on a system of free hospitals that existed long before the NHS. So what is the model of the NHS as we look forward, as we change treatments, as we get different approaches to care? How do we reach out? Is the future of the NHS about being in hospital, or is it about being in communities with access to local services? There's a whole load of questions, and I think that this provides us with a forum to be able to have some of those conversations and to start to do it with a voice that's then heard, as opposed to being fobbed off with a, well, that's just how it is.
They keep closing the stroke beds in hospitals, and to me, especially in the area of Somerset where you've got such an elderly population and you've got so many people with strokes, that they've just closed 6 now in Willerton, which to me is wrong.
And I hope, those are the kind of issues that we know that people want to talk about. So, Bertha, here and then...
Earlier on, I identified myself as a citizen because I wanted to come here with a blank piece of paper so that I could learn. But going back to 2006, when Rosie Winterton was whatever the type minister for health, she developed at Warwick University NHS Centre for Involvement, and I was a lay project worker. But then and now is that we didn't have LinkedIn, we didn't have Twitter, so in terms of engaging it was actually face-to-face, it was regional and local meeting, and because it was based at Warwick University, it was too centralised and not localised, and this is where your communication strategy can work. But let's be real, that engaging with potentially 60 million people, because it's an upward stream, you're going to have an assembly of 250, so you're going to have to stratify, people that wouldn't normally get involved with those that actually got the knowledge to take forward, because the business of NHS England, they undertake certain functions that they're not going to communicate with us about. I've argued in our area that we shouldn't make no contribution before we're top sliced on our budget to the Clinical Academic Awards, which goes to surgeons for their Oscar, for their, platinum awards, which can give them another 30,000. I never agreed to that. Our CCG, is PPI's strategy 3 weeks ago, wanted a governing board to agree to it. I objected to it because the only people they consulted was voluntary community sector organisations, and the reality is that it hadn't engaged with service users, carers and public. I'm not saying it was wrong, but it seems that the default position appears to be, depending where you are, to speak to the voluntary community sector organisation. But I think it's appropriate for some groups that may advocate for those organisations to speak on their behalf. But taking Cliff's point and that, if I was down in his area, I'd look to see what the NICE guidance was actually saying, and then check to see whether or not the wards were complicit in terms of the expectation from the technological appraisal, if they exist, and from the guidance. And I think we have to believe in that system unless something else can actually trump it. So I don't think we're going to create all the answers. And let's not forget, each CCG and local authority will have had their own equality and diversity engagement plan. So ineffective, excuses like seldom heard and hard to reach are excuses for ineffective community development engagement.
Yes.
It's just a thought. They've been doing it for years.
Thought, yeah.
If you look at, areas like Toxted, Jayswick, Hull, they've always been up there in terms of indices of deprivation, but the PCTs have always been given additional formally funding to actually reduce it, but they never have, because unfortunately those areas are still up there 12 years after the indices were published and reviewed and that. So some things are a little bit difficult.
Yeah. Lots. Bev, and then Michael.
I'm here today with two hats. Obviously, with me working with tenant participation, and as a citizen, a user of the NHS, family members use NHS. I sent out an invitation to our tenants for this event. I got one reply back from a lady who is disabled in a wheelchair. She needs a carer. And she said, what's the point? I was pleading with her, please come, because this is where you can voice your opinions, and she just wouldn't have it. And it was heartbreaking, really, because I thought, well, here's your opportunity. We were going to pay for her transport, we would pay for a carer for the day, and she still wouldn't come because she hasn't got the faith in being heard. And that's what worries me. So I would like today to take something back, to say, here's your voice, use it. On a personal note, I'm not that happy with, say, for instance, you got somebody who has a transplant. They used to have them in Exeter, now they've got to travel to Bristol or Plymouth. For me, they're not actually looking at the user here.
Yeah.
But, anyway.
But they're two very closely related points, and is that we're not going to manage it today, but our aspiration is that people would see NHS Citizen would give people the confidence that they could be heard. That's the highest standard to set for ourselves, I think. Michael, and then over here again.
Yes, I'm very interested in what I'm hearing. A little bit about me. I'm a patient. I'm a user of the NHS. I've had a broken back, broken neck, 3 strokes, a heart attack. So I've had my fair whack, and I've tried to put something back. I'm on drugs, trials, programs, and other things. I'm a moderator for a new hospital opening shortly. I'm an evaluator of NHS tenders, orthopaedics at the moment. I've sat on workshop groups setting up specifications for tenderers. And systemically, I find lots wrong with the changes that have occurred so far. And when I point out to whoever, I'll give you an example. We've talked a lot about Health Watch. My contacts with the Health Watch say there's a problem that Entram View has no teeth and needs more. And there doesn't seem anywhere available to address that problem or identify if it is a problem. There were over 80 of us on one workshop. We gave feedback about 111, and what we were saying actually happened. South West Ambulance, I'm really glad to see them here today. My particular surgery, if you found out of ours, it put you straight through to St Leonards-on-Sea. Their call centre handed. I did a straw poll in a large hospital in Somerset and asked about providers, which service had they gone for? Was it the NHS Direct or was it South West Ambulance? The only people that were pleased were South West Ambulance that came out of the straw poll. When I tried to put that straw poll result to other organisations, including people on the CCG, PPG Chairs Network, it was not accepted or taken, no notice taken whatsoever. Now, if this NHS Citizen can be a route for those perspectives coming from patients to get through to NHS England, then it has to have every effort put into success. Some of you know I have a current issue with NHS choices and private provider data not being available, so informed choices cannot be made. I hope that goes somewhere. It's on the PPG Chairs Network meeting in Somerset agenda for tomorrow. It's taken me 18 months to get it there. Anyway, That's where I'm coming from. It has to work. Something has to put it all together, or we're all fighting each other.
Yeah. Last point, and then I'm going to try and wrap this, and we're going to move on time-wise. Oh, I'm so sorry. So sorry. I've been looking over there. I do. Right, and then you will have the last word.
I was just interested that there's obviously the Discover and the Gather, and we've talked a lot about some of the individual cases and concerns that people have. But how does the NHS Citizen model tally with the NHS Constitution? And the main reason I mention it is because in there is a responsibility for the NHS to, it's dictated in law that they have to respond to feedback, but also it dictates the responsibility of the patients to give that feedback, to be proactive in their voice. And there will be 100 stories alone in this room that people will have encountered a barrier to giving that feedback, and I accept that. But I just wonder how the model is going to support or challenge or dovetail nicely with the Constitution.
It's a very, very good point. I don't think any model in the world will change that. That's why this is about behaviour change. And this is why the human relations strand of this is so important. Because actually, note that you can make the best form in the world for giving feedback, but if people don't use it and people don't listen to it, then it's pointless. This is about how you actually how do you create an environment where your tenant feels like it's worth giving that feedback, and that because they feel confident that the system is going to listen to them. And that's all about behaviour. We'll do the best design we possibly can, but it's all about the behaviour. The last word.
Thank you. We're constantly being told that there's no money available. No, I'm not being rude, but I'm sure you're not volunteering. Or you cut here now.
No.
So where does money suddenly come from when beds are being taken away from community hospitals? I live the far side of East Devon, and it's ridiculous that I have to travel so many miles to a hospital. I've been registered disabled for nearly 40 years. Mm-hmm. My doctor looks after me very well. So does the hospital when I get there. But if I can't drive, it takes 2 hours on a bus to do it. Yeah. When we've got a hospital within 10 minutes walk or whatever, and they're closing it down. Now that, as far as I'm concerned, is all wrong. There's too much money being wasted in the National Health Service by so many people who are not medically trained or even have any idea. And I was around when the National Health Service was first formulated. I even voted for it.
So I don't know if Olivia wants to chip in, but for me, I think this comes back to Olivia's point, which is that we have a health service which is designed for a society which has really, really changed. And I really hope. I live in West Sussex. I really don't want to live in a city, and I don't want to end up with the infrastructure of this country being arranged around urban centres. I want people to be able to live in a rural community and to be able to have access to really great care, because the technology is there and it is possible to do it. But I don't think at the moment that we're having those kind of shaping discussions personally. And so if we do this right, I would hope we're creating a place where that kind of conversation could happen, because I don't think it's happening really effectively anywhere else. That's my personal view. Yeah, well, I'm a militant optimist. Right, shall I?
I think, particularly with the speech talk takers, it might be good just to take 10 minutes for people to have a comfort break, go and get coffee and stuff, and then we'll start back on time at 11:25.
Brilliant. You're going to fall off your chairs. So, yes. All right, look, thank you so much for that. We will let you have a quick break now. I think one of the things, just before we break though, can I just ask, does anybody want to re-identify themselves as a citizen? I was very struck by that comment from the room, because I certainly, I'm here facilitating it. I'm a citizen. Anybody else a citizen? Yes, we are NHS. Yes, thank you. Yeah. Grab yourselves a cup of tea. We'll crack on after that. Thank you very much. That's what I like. A hush falls upon the room. Thank you very much, Malcolm. Okay, so what we're going to do now is I'm going to just briefly describe the exercise we want you to do. Then we're going to ask you to work on your tables for a bit, but we're going to move you around slightly to make that easier because it's very crowded in here. And then you'll probably do something very, very constructive, completely different to what I've described, which will also be fine. But I'm going to have a go at directing the conversation. So when we do these regional events, we tend to come with a couple of design questions. So stuff that we know that we haven't got the right answer to, that we want to take to a bigger group and get advice on, and get a better input. Because obviously, you know, sort of the point of this, as we keep saying, that it's co-design. We're doing this together. The question we want to look at this morning is about boundaries. Is that it's very, very tempting once you start doing to say, well, you can do everything. And we did have a brief period at the beginning of the project where we thought NHS Citizen is the solution to everything. Clearly, that's not the case. So we're very interested in boundaries, and we've got kind of 3 big boundary questions. I mean, the first question is, what are the organisations and the structures which were already there, which need to be connected at the edges or within the Discover space? Healthwatch is a perfect example of this. But where do you think the NHS Citizen needs to connect to other stuff? Don't spend ages on that because we've done some mapping already, but if you could, because we've got a lot of diverse organisations in the room, it'd be really interesting if you could have a conversation about how does NHS Citizen connect to other stuff that's going on, the boundary stuff. The next point is more of a subject kind of boundary, is that can you imagine the kinds of questions that you would like NHS Citizen to be ready to answer? So a boundaries question. So you're all, you know, in the main, you're experts on this stuff. And so where can you see that there is a gap for questions? Where can you see that actually at the moment the mechanisms that aren't there don't answer the questions effectively? And we had some really good examples of that earlier. So that's the second thing about boundaries. The third question about boundaries is about points of entry. So if NHS Citizen exists in the future, I hope, is that where would people come into contact? And that was partly James's point about where's the point at which you connect to NHS Citizen? What's the boundary of it? When would it first, as you know, sort of Catherine Citizen, where would I first encounter it, or where would I be aware of it? Where does it touch people's lives? So those are all questions that we see as kind of like understanding the shape and the scope of this.
I just want to ask.
Oh, sorry, I need to get you to go onto the microphone. I'm sorry. Well, I'm not sorry, because the people at home are grateful.
This might sound like a very simple question, but could you clarify what NHS England is for and what it's going to do with all of this product?
Oh, that's a terrible question. What is NHS England for? Olivia. Harsh, but good question.
How long have we got?
Well, that's the key.
Okay, so NHS England is a commissioner of services. So NHS England commissions primary care, it commissions armed forces and health and justice services, and it commissions specialised services across 212 different service areas. And it's also responsible as a leader of the NHS. So how it...
Prisons?
Yes. Prison health, not prisons itself.
Yeah.
That's other people in the room. So it's also a leader of the NHS. So in the way that NHS England behaves, it's setting... Oh, I'm sorry. Come closer. It's setting a series of expectations. And it's responsible for policy and strategy. So how the NHS behaves and operates, and a lot of that is also about the service redesign and what the future looks like. So what is the NHS that we're going to have in 5, 10, 15, 20 years, given the health needs that exist in England? It's also a supporter, so it's a supporter of clinical commissioning groups. It's a supporter of other NHS organisations to enable them to do their business. Does that help?
I think I know what it's for, but I'm wondering about the information that... I think I know what it's for, but I'm wondering about the level of information that you've given us in the NHS Citizen pack that we've already had, and what people understand. Have people got a common understanding of what we're producing all this information for?
That's a really helpful reflection, actually, in terms of the information.
Yeah,
that
we don't
use.
really. We just assume people know what
We
NHS
do.
England is. Yeah, we'll change
So
that. No. It's a great. No. It's that this is why we get stuff out there. So
So
that
we
is a
would
great
benefit from having some descriptions of CCG responsibilities, of NHS England responsibilities, and a kind of, but not in a massive way, but in a nicely succinct way. We can do that.
But your question sort of illustrates that point about kind of like that second question around scope, which is that when you start talking about NHS Citizen, it's very easy to just think it's everything, but it's not. We're trying to focus on NHS England to the best of our ability, and those particular things. But we think that in the same way as NHS England has the leadership role that Olivia's describing, is NHS Citizen should be able to produce information and richness which is useful throughout the whole system. So is everyone clear on those three questions?
No, because Catherine, what was your third question?
My third question is points of... that was third. Second question was the scope of questions. Honestly, you just can't get the teammates. Right faster. Okay. So first question, what are those organisations that need to be connected to? And again, we've got the police here, we've got the council here, we've got the ambulance trust, we've got a lot of those connected organisations in the room. Please give us some advice about how does NHS Citizen intersect with other things. Secondly, what's the scope? What feels like an NHS Citizen question to you? What's the scope of the kind of things which NHS Citizen could be talking about? And the third point is points of entry. How would you encounter NHS Citizen? What's the point in your experience as a patient or as a citizen that you think that people would encounter it? Does that make sense? Okay, well, I'm going to circulate anyway with questions. Okay, so we're going to move people around a little bit because if you're all humming, you've got about 40 minutes to work on tables. If you all do it in this room, it gets really loud. So I'm going to ask two tables I've already asked. Here's one I prepared earlier. These folks and these folks are going to go and work in the room round the corner, which Nagina is going to take you to. And you guys are going to go and work out there. Thank you very much. And then if I can ask you guys to shuffle around a bit, hopefully it'll be quiet enough in here that everyone is going to be able to hear themselves, but we'll have another go if not. So those of you who are moving, move. What I'd like you to... You're going to be doing feedback afterwards, but if you could capture things on the bits of A5 paper, we're going to stick them on the walls as well.
Can I just give you an instruction on that? It's really important. We're going to stick... These walls are sticky, okay? Things will stick to them. Not people, just paper. If you write on the cards, can you please write big and try and be succinct? So there's loads of bits of paper. You can use as many as you want. So one thought, one idea, one issue per card in as clear writing as you can.
Could you just demonstrate big for us? Okay, this may seem really, really petty, but the number of times we get these back with tiny writing on that we can't read.
So an idea should be 3 to 5, maybe 7 words that you can talk around, not an essay. Okay? I'm quite arsey about this, if I'm honest.
She is
I'm quite school teacher-ish. So if you could stick to my instructions, I'd really appreciate it.
Or there'll be trouble, everybody. Brilliant. Move out, teams. Thank you so much. share now. Special chair in the middle. Sit in the middle and think about what you've just done, Leslie. Okay, Pete, are we... Excellent, we are live. Hello again. What we're going to do now, because as you see, lunch is already building on the table outside, is I wanted to go round the tables and get feedback. As I say, we set you 3 questions. What will inevitably have happened is you'll have a much more interesting conversation than anticipated. So I'd love it if you gave me feedback on those 3 questions, but have at it. If there was other stuff you talked about, let us know that as well. Now, these guys have particularly requested not to go first, and since they were very organised, quiet and compliant, I'm going to let them go with that. So who is going to go first instead? Them. No, I'm protecting them. Will you? Excellent. I check my privilege. Brilliant. Thanks, Susie.
Are you all happy that I... We actually only got as far as the first question because that's developed quite a lot of discussion. And I suppose, to sum it up, we came away with the idea that by calling it NHS Citizen, that actually is quite limiting because we think you need to connect with a whole host of other organisations, such as the third sector organisations, such as social care, such as Public Health England, the police, local authorities. So by branding it, if you like, NHS Citizen, it rather or potentially stifles conversation.
Okay, well, where we were trying to make it more controllable. So did you have another idea for what we should be branding it?
No, I think it's a short answer.
We have often said it should just be called Citizen.
We did actually say Citizen.
Okay, that's okay. Can I get? Does anybody have any comments on that? Okay, Frank. Frank, wait for the mic.
I think ultimately, the service of the NHS is there for current patient, past patients. A professor of public involvement asked a question in Yeovil a few weeks ago when I was there at a conference. When is a patient or a user of services no longer that user of services? And I had a quadruple heart bypass about 10 years ago, and what reminds me that I'm still a patient is when my GP practice reduces my 2 months prescription down to just 7 days because I won't go for my annual cardiac function test. If I went when I should have gone, then I wouldn't have been hassled with having to go back every 7 days rather than every 2 months in between and that. So in that respect, that's what reminds me, and I'm sure other people with long-term conditions get on with their lives, but what's being described there is a default position where maybe the voluntary community sector have got something to say on my behalf, which they haven't. They can support nationally through the British Heart Foundation, through Hearty Voices campaign, to get that voice over, to ministerial groups and such forth, because not everyone has got the capacity to operate at that level.
No, that's a good point. Okay, I'm regretting opening this up before I got feedback from all of the tables, if I'm going to be honest with you as your facilitator. So I think, unless anybody's got a burning question, I think I'd quite like to go round all of the tables and make sure we've got contributions from all of the tables and then open it up to general question. Is that okay? Because otherwise, everyone's going to say something really interesting and then we'll never get to these people who want to go last. Okay, so which
Can I just add in, I think we did sort of touch on the third question as they're written up there about what kind of conversations should...
Yeah, the thing that may or may not be NHS or not Citizen, which was about difficult, contentious and public value conversations. So being a space where you can actually have some of those conversations that people on an individual or a single organisation might find really hard to have, but we really need to have those conversations.
And giving support to those people so that they can...
Sorry, microphone.
And giving support so that you might ask someone to give feedback, but do they have the wherewithal and ability and can they be bothered to do that? And if you perhaps make it so easy for them, or in fact actually literally ask them and take it from them, will you get a broader level of feedback?
Okay. That is very interesting. That kind of, these are the questions that fall in between spaces. Basically, is the thing which we want to make sure that how we describe this, we want to attract the conversation that fall in between these things, and we want to help people participate.
We even did actually mention the supermarket thing, where you get your little green token. Something, I know that's too simple, but this is your local organisations. Put your token in the one that you want.
Yeah,
it's there for you. So that's simplicity.
Yeah, I find that a very interesting exercise, because I stand there looking at the 3 boxes and I realise exactly my own prejudice about who I want to help. It's really quite salutary, but it is interesting. Everything with animals, basically, for me. Which table wants to go next? Oh, go on, tables, because you're all quite chatty. Okay.
Right. We had a rather interesting conversation on this table. I'm not sure we actually answered any of the questions. But one of the things that we did, and I think the most important point to come out, was around the groups and organisations, which is, we all have and know huge numbers of groups and organisations and relate and interact with them. And actually, to sit down and list them all, I mean, I've put up there, and this is just the few that I've managed to interact with and forge a relationship with, 352 plus organisations, and not all of those are health specific. These are neighbourhood groups, these are play groups, these are all sorts of other things. They're not just health orientated.
But does that perhaps put what you do on the boundary of NHS Citizen, because you're an important connector between NHS Citizen's conversation and conversations which are happening outside of that system?
No, I think health and well-being extends beyond some of those comfortable areas of health, social care and public health. Have to look at sort of like groups that can connect to one another, whether it's a creativity class, music class. So yeah, it would be on the boundary, but it kind of like overlaps, because each person will define how they connect and how they keep well. So that's about self-determination and that taking ownership of the connections that they make and the things they want to do.
So I guess so one of the things which I think this sort of came out in your group as well, I think, which was this is the relationship between a system which is completely open, where anybody could participate, and a system which does have some boundaries because it's trying not to replicate stuff that's already going on. And we're trying to hold those two ideas alive at the same time. Does that make sense? And I think that, does everybody else feel that that's partly what we're wrestling with here, is that how do you make sure it's open and accessible and available to everybody, but also make sure it's not duplicating stuff that's already going on? So sometimes it's quite helpful just to own the dilemma a bit.
I think it's a dilemma that we've, working in the CCGs and commissioning bodies prior to the CCGs, it's one we've always struggled with. And we have always found that the only way that we can do that within the resources we have, and that might be the number of staff working, the amount of money we've got to do it, is to actually work with representatives. But our wariness of that approach is generally attributed to how representative those representatives truly are. And I think that's a really key issue, and it's about finding a mechanism that allows you to work with representatives who are truly representative, and that's the challenge.
That is a brilliant articulation of one of the questions that we've had in our minds, and we're not probably going to get into that today, but we will be picking that up in other workshops and things. So thank you. Yeah, you're spot on. I think I completely agree with you. Who would like to go next?
I'm stood here.
Well, Olivia would like you to go next. Yes.
It was just going to say walking across the room again.
I think we echo a lot of what's already been said, and certainly there were the questions about not duplicating because of the confusion it can cause with so many people, and perhaps having to repeat their story so many times, whereas we've always tried to get to one point of contact. We're also looking at sustainability. You know, what's the lifespan of the vision, etc., etc. Some of us have been around the block rather many times and seen so many iterations of different things, from Chippy right through to Healthwatch now. You know, so there is the issue about sustainability and future funding, etc., etc.
Yeah.
But definitely not wanting duplication where there are already good networks in place, but capturing that voice, and the democratic part was quite an appealing one.
Okay, anything else? No. I mean, when you say capturing, because I'm a sociologist and a technologist. It's like I'm totally from the 21st century. Is that capturing? If you capture things digitally and make them available throughout the whole system, then actually, you know, one of the promises we should be able to make is that if you've told NHS Citizen something, whichever you know, whether or not it's via Healthwatch or it's via something else, is that once we've been told it once, we shouldn't need to have it repeated. And in technology terms, that's actually not that's a very relatively straightforward thing to design in. In behaviour terms, making sure that we always listen to stuff is a different challenge. But those two things together, hopefully, give that solution.
There was another question about talking about points of entry, but what's the point of entry backwards? Because this has to be a two-way flow. Okay. And if things are coming up to NHS Citizen and taking forward to the Assembly, how does that then get fed back, say, to the CCG? Particularly if the CCG are already engaged in a work programme, are engaging with its local community, and perhaps something comes back via the Citizen route, which is outside of all of that. What is the role of the point of entry back?
So, and the reason I'm going, so I'm having facilitation pleasure, which is that we designed, it's like, I think we might have got it right. So this morning is, I've only had a lot of tea this morning, no coffee, but quite a lot of tea. It's the caffeine, you know. Is that this morning we want to talk about boundaries, this afternoon we want to talk about exactly that issue, is how do we make sure that once NHS Citizen knows something, stuff doesn't get lost, but also that we always close that feedback loop. So hold that thought and bring it back after lunch, fueled by quiche. Thank you. As you're standing there, would you like them to feedback next?
I'm happy for anyone's feedback.
So it's a bit, honestly, she's guiding us.
I won't repeat what has already been said, but we did come up with a couple of different things or related to it. First is really a reiteration of what's just been said, which is NHS Citizen must be responsive and feedback. In other words, you said, we did. Yeah. It must be made clear. Secondly, we felt that there was no one way in, that there were a variety of different ways in. Thirdly, a third point that we came back with was, what about self-care? Because there clearly has to be some way in, if you like, for those involved with self-care rather than the formal care. A fourth point was that clearly with the ever-convergence between healthcare and social care, this must be a consideration. And again, it's a reiteration of the point about the naming of it. And have I forgotten anything?
Well, there was just going back to the self-care point. Going back to the self-care point, I think we made the point that actually NHS Citizen maybe needed to be involved in a process of empowerment so that that self-care becomes a reality for larger numbers of people. Because I think possibly a large usage of the NHS is lack of confidence and possibly community supports to actually get on and deal with your own health matters if they're of a certain level. So I think it was that linking it to what NHS Citizen could valuably be is possibly a good empowerer of patients via good information, influence on commissioning decisions about community support arrangements and those sorts of things.
And one point which I did miss before was that for the hard-to-reach groups, one way of tackling
getting input from them was to piggyback on other groups that already exist and which do already involve those hard-to-reach groups. For example, young people. For example, gypsies and travellers. For example, the homeless. If you piggyback on the support organisations already there, you might well get better feedback and try and do it yourself.
Yeah, no, that's really good advice. I'm very struck that the self-care point, that hasn't been articulated in a session before, and I think it is a very, because one of the things we struggle with we're not struggle with, it's kind of like, we're thinking about it very hard in a positive way, is how do you show very quickly why operationally, practically, it's really better to talk to people and involve people. And the self-care point that you're making there is a very meaty area to be able to show the system, look, actually involving people more effectively actually helps in the care delivery as well as just in making us all feel good. You know what I mean? It's a nice area of inquiry for us, so thank you.
I personally liked the name NHS Citizen. We're all citizens, and hopefully all of our input from whichever organisation we're from will help us all. So.
Yeah, thank you. I'm going to go... Oh, look, they're actually volunteering. Go on, Olivia.
Hello, I'm not entirely sure we answered much of the questions. We came up with more questions. One thing we did agree on was that the main impetus for engaging Joe Blogs, well, there's two reasons you'll engage. One, you're paid to, like I am, or you have an experience which motivates you to do that. And so one question, the key question that we had was, actually, what are you going to do for me? As a professional, is this somebody else I need to report to? Is somebody else who wants to report of me? This is another meeting I've got to attend in my tight timescales. And actually for a patient, and this is talking about getting the information back out and making sure that those who need it, who've contributed, get a response to that contribution, is actually how is it going to affect me? And leading on from that, we were talking about how the gathering exercise, so all the information comes in, how do you stop that turning into a Chinese whisper? How do you stop that story changing?
Okay. So on those 2 points, I'm not going to try and answer those 2 points, because I think the first one is that I think one of the things that's been coming back in feedback as we've been out and about is that we probably need to do a workshop which is very much focused on people who are doing patient participation already, and that's something we want to pick up as part of the human relations workstream. So we've got your details. We'll make sure that you would be invited to that. I think in terms of how do you stop the Chinese whispers, we can get into that later. But for us, making sure that the information is open and accessible to people is quite a big part of building that. Is that the more open that you are with the data, the less likely you are to end up with the Chinese whispers. So it's how do you make sure you preserve people's privacy enough so that you can have a very, very high standard of openness and transparency, and that's one of the questions in our minds. So that'll come back at another session.
Just one more point. With the other thing we raised was about education, and a lot of clinicians now will go through various different educational tools. You have to have a degree now to be a paramedic, for example. So one of the organisations that NHS Citizen needs to deal with is the educational facilities.
Yeah, good point. Yeah. These guys...
It's been deaf now around the room.
I know. There's only 3 tables left, and then... Go on.
We started looking at those questions, but felt they were leading us down the road of creating structures before we were really happy about the role of NHS Citizen. And... So we started to look at that, and actually, well, I felt, I don't know if anyone else agreed with me, but I felt that, in a way, it's questionable whether NHS Citizen should be gathering its own data or not necessarily using, as people have said, piggybacking onto other data, using, if you like, creating a super evidence bank that it then uses to gather intelligence that helps to inform decisions, as opposed to actually going out there and confusing people more with yet another quango, as someone mentioned earlier on, gathering more information, because there's stacks of information out there, stacks of data that could be used. And is the resource for NHS Citizen going to be focused on number crunching and analysing the data, or is it going to be about creating yet more data?
So just to be really clear on that, from our point of view, is that the first rule needs to be find the data that's already there, find the conversations which are already happening. Then, when you look at it, it might be that you want to go and say, well, actually, here's a group of people that aren't represented here, or this is a group of people who aren't yet involved. But the starting point has to be find the networks which are already there, listen to the information that's already being heard. Because if we go out and try and get people to tell us stuff that they've told other people before, firstly, we break trust immediately, but it's a waste of time and energy. So our intention is we are connecting together information that is already being collected in lots of pockets around the place.
That's fine, but that then may lead to NHS Citizen wanting to know more information, perhaps using those channels again to gather that rather than doing it yourself.
So when we talk this afternoon, that kind of like iterative relationship, which is, well, we've heard this, but we want to check it, because actually the idea of an issue doesn't have a nice clean cycle. There should be iterations of exploration and questions and stuff like behind that. How do we set it up so that we can always get back to people and respond? Yeah, so those are good questions. Anybody else on that table before we move on? I'm just very aware of lunch and the fact we need to finish soon for lunch.
James, John.
They can chip in. Right,
Some bloke beginning with J, in fact.
Yeah, I'll try and make this brief because you want your lunch. A lot of the points have been made. Basically, I think we started off from the point of that a lot of these networks exist. And I think it has been said several times. Let's not reinvent. Let's get into those networks. But as Justin was saying, obviously we are, and Sally was making the same point, that when you hit these networks, you are looking at representatives of representatives.
Which is,
So with social media, you can obviously then invite those representatives to get people they represent into the process and then snowball from there. So you're then making those networks. So you can build upon that. One that hasn't been mentioned was the primary hits on Google. Get your Google presence up. Obviously, when somebody says, my father's got Parkinson's or something, they go onto the internet. NHS Choices is quite often the first one. There's then a discussion thread, make sure that, so it's picking up on those existing networks. So that's an entry point. Scope of questions, I think we were sort of saying basically it's, you've got to use this process, I think as Steve was sort of alluding to, is what are the conversations going on out there? What, we call them barbecue conversations. What's going on out there? What are people talking about? How do you then make that into a sort of, what are the key points? How do we then go and re-ask and unpack those and get those conversations going to then inform policy? And unless anybody else wants to chip in, I'll leave it.
So two things. One is that question about the boundary between what are we hearing and what are we going to do about it is the discover, gather boundary. And we've got lots of work that we're doing on working that out. But there'll be other sessions where we dive into that particularly. I think one of the things which is coming, I think it's a really honest question, this point about how do we know when someone who says they're representing people really is representative. And I think I'd like us to capture that as a question. I'm saying, because Anthony's writing up the notes at the moment, is we will capture that as a question and we'll bring it back for more discussion. It's a really critical point.
More appropriately, we sort of alluded to triage because somebody said that often you're going to hear those that scream the loudest, and we all know from triage if they're screaming, they're not dying.
Yeah, it's the quiet people you've got to worry about in triage, isn't it? Yeah. Last, but by no means least.
The good thing about going last is we don't have to repeat everything everybody else has said. So I'll just pick up on one thing that we probably feel. We feel that entry is very good for the under 60s. We're really concerned about those who are not connected. What about those who are out in rural areas? Connectivity is a problem. We're back to, yes, you've got to have on the ground people who are already linked into organisations, but if they're not, if you're trying to reach those hard to reach groups, a lot of them, certainly within Living Options, we know that 80% of our service users are not connected. Okay, so that's a very big issue. The last thing that I think we would pick up is the fact trust. The word trust. People have stopped trusting. What is NHS Citizen going to do to rebuild the trust in what is happening out there for the NHS?
And I think that's a lovely point to bring this session to a close, which is that what does it need to do to be trustworthy? And there's lots of things about being open, about the feedback stuff that we're going to talk about later, but it's about the behaviour within NHS Citizen. Is it trustworthy behaviour? And you're right, it's absolutely critical. I just want to say that on the connectivity point is that we are building in a digital by default way. We are building using the best technology which is available to us, because we think that, because on all graphs, the number of people who are digitally excluded is dropping. But what that means is we have to spend a lot of energy making sure that those people who are digitally excluded have a route in. We expect those numbers to drop off over time, which is why designing for the future, we design digital by default. But in the short term and the medium term, probably, helping those people is going to be a critical part of the activity.
If they haven't got computers, people can't be told, well, they can go to their local library, because as we well know, Devon County Council is cutting on their libraries, as it is right around the country.
Yeah. Okay, well, you're now the person that's between us and lunch.
The other part is there are no young people here today, and I mean
James
people under 18.
James Young.
No, I mean people under 18, and I just wonder if you've got a parallel process for people who are under 18.
Yes, so I don't know if you want to... We're going to be speaking to the Youth Forum and involving them specifically in some sessions, but... Do you want to...
So, I mean, young people, actually, they're not hard to reach. Rosie's at the back, she's only 14. It's all right, don't worry.
Not saying they are hard to reach, just saying where are they?
There are most, I would hope, at school or college or university. So, getting people here during the day isn't necessarily the answer, but we've got the NHS England Youth Forum, which is now set up. It's a start, it's not the answer. There is a big question about how do we have those conversations? How do we have them digitally? How do we connect with schools? How do we connect with other places young people are going and talking in a way in which they can connect with this? So I know that my daughter will engage with this conversation a little bit, but actually it's mostly going to mean nothing to her, even though I've asked her to try and do a social reporter role today. I'll embarrass her mercilessly. But if we had this conversation about the language we use needs to change, and we need to talk in a way that people can connect with. So, no, we know we're talking to the people in the room today, and we're talking to the people who are going to connect with us via Twitter today, but that's a part of a process and not the whole process.
We got really, really strong and powerful feedback at the NHS Expo around accessibility and access and inclusion from some really, because Olivia and her team had convened some very kind of, a really diverse group of people into the conversation. So we're trying, as we do the design, we're trying to firstly make sure that we're living the dream in terms of the accessible information standard. And acknowledging the fact that, for instance, I talk full fat wonk. I'm really bad at remembering that language point. We're trying to mitigate that in the team a little bit, but also to work directly with those groups. So we're going to have an access advisory group, and we're going to have a technology advisory group as well. But the access advisory group will pick up those people who we don't find in the room to say, how could we make this a welcoming environment? How can we make this work for you? So that's quite a big strand of activity. And we're going to have to work with people who are already doing this, because there's a lot of... again, we don't want to duplicate it. So thank you. As I predicted, you didn't end up having the conversations that we asked you to on your tables, but I think we still did do quite a lot of... there's quite a lot of interesting feedback there for us on the design as a whole, but also around those questions. I think a couple of really interesting kind of things we hadn't heard before about, the representation point, I think, was just very nicely put. The self-care point, again, that hadn't come out previously. And what's reassuring is that actually in terms of some of this boundary stuff, I think the way you're expressing it is that we need to sort of inhabit those spaces in between a lot of other organisations is a really great way of expressing it. So thank you very, very much. Go and get some lunch now, and then after that I'm going to be much quieter, which I'm sure will be a relief to all of us. And Anthony's going to take us through the next exercise. But we've got half an hour for lunch.
We're going to stretch 40 minutes.
40 minutes for lunch. 40 minutes of key shooting, team.
So
have at it.
Can I just, before we do break, if you can come back really promptly after lunch, we're going to aim to finish at 3:30, because I know there's a few people who are on booked ticket trains. Oh, there's a camera going. So if we can be prompt back, we will aim to finish at 3:30, so people who need to can get away. Is that okay? Cool.
the afternoon, and we did say that we'd finish at the latest by 3:30. For the rest of the afternoon, we want to think about something a little bit more detailed than we looked at this morning. So this morning we talked about the system as a whole. Today, as I step back from the view of the screen, today we are. It is very difficult. It's very difficult. This afternoon, we're going to be thinking about some of the specifics about how we make sure that NHS Citizen delivers results. One of the things that really struck me about the conversation this morning was about how people wanted to trust it and felt that trust was the necessary thing to make this work. And as someone who works on citizen democratic participation for my day job, I know that trust in the system and the process is hugely important. So how can we make sure that NHS Citizen is a trusting and trusted environment? So Leslie and I are going to ask you to do two bits of thinking. I'm going to ask Leslie to introduce the first, and then I'll talk a bit about some of the more systematic stuff in a moment.
1, 2, 1, 2. Okay, I feel like I should be crooning or something. Maybe later, if you're all really compliant. For a little song. So, first of all, just to introduce a little bit about human relations and what does that mean, human relations. So there's something about the way that we relate to each other as human beings. A key component of the NHS Citizen model is it's about conversations. And conversations happen between people, not so much between roles or between systems, but between people. So we're all wearing different hats. Some of us are citizens, some of us are Health Watch England, some of us are various community groups, but we are people in those roles. And what we were doing this morning was doing a task. The task was set very ably and clearly by Catherine, and people beavered on with the task. How we did the task determines the nature of the quality and the culture of what we are co-creating here today. So, did you feel that you were listened to on your table? Did you feel that you were able to say the things that you wanted to say and that people heard you? Did it feel smooth and collaborative? Was it tense and fractious? All of those elements of your experience tell us about the relationships between the people in the system. So this afternoon, we're going to do another task, as Anthony said, but we're going to do that task with an awareness of the nature of the relationships in the room, because almost there's a theory that says that everything is holographic. So when you're in a system, just as in the human body, every cell is a complete mirror of the total system of which it's a part. So we, as the co-creators of NHS Citizen here today, are enacting what that new way of working will be like. So if we can't crack it in the room, how are we going to crack it with Joe Public, which is how everybody's been referring to him and her? When we meet Joe Public as NHS Citizen, what will it be like for them? Because whatever it was like for us is an indicator of what it will be like for the system when we're in its widest sense of operation. Does that make sense? Yeah? So, in your tables, if you just take 5-10 minutes and just share the reflections from you as people, what was it like working this morning? 10-15 minutes.
What was it like? Interesting, good.
And what we decided to do was to introduce a pause here, because if you noticed, if you were listening to the room, you suddenly started to get really animated, and that showed that you'd left reflection, and you were actually probably starting to talk about content again, so you wanted to get back into some task. So, obviously, we're not going to do a feedback session because your experience is your own, and it's for you, because it's what you experienced. So, just pause, and Anthony's going to introduce the next task.
However, that doesn't mean that the things that you've been thinking about are going to be lost, because the task here is about the culture and about the way of working. So I want you to take those thoughts that you've been having about how it's working today into your thoughts about how it might work in the future. There are 2 promises that the NHS is going to make as part of NHS Citizen, and I would say up front that they are very difficult to deliver. The first promise is no wrong door, which is you might have come across in social services, the idea being that if you arrive at NHS Citizen with an issue, it is the responsibility of the system to take you to the right place. It is not the responsibility of the system to say, actually, no, you need to be over there. You need to be with Health Watch. You need to be somewhere else. You need to be somewhere else. Yeah, it's a bit like in John Lewis. Down the road, if you walked into John Lewis and you said, in the lingerie department, where are the cookers? The person in the lingerie department would take you to the cookers. They actually have an order from their boss that that's what they do. They don't say, oh, it's three floors down at the back. So first, how does the NHS Citizen system deliver on that? But also, how does it deliver on the second promise, which is every issue answered? Now, those 2 promises together are the core of what it means to be in the NHS Citizen system. First is you know that you'll get to the right place, and the second is you know that if your issue is one that people want to talk about, if it reaches some kind of hopefully lowest possible threshold around there being sufficient people to talk about it, it will get an answer. Now, the nature of that answer might be, well, we can't handle it, or no, it's not like that, it's like this. But an answer nonetheless. So the task for this rest of the afternoon, till 2:45, which is when we're going to stop and feedback and take in the rest of the afternoon session, is first, how can NHS Citizen deliver on those promises? So if you work in an NHS organisation, how would you receive something from NHS Citizen? Who in your organisation would field it? If it's like an MP asking a question, where does that go in your organisation? Or a councillor saying, what's happening with the surgery on Mill Road? Second, if you're not in an NHS organisation, or even if you are, how would you want to feel that that was being responded to? And that goes to the second question, was how do you make that experience trusted? So there's no point in saying NHS Citizen is there if no one trusts it. So how can we ensure that it's a trusted space for people to know that they can get to the right place and know that their issues will be answered? And finally, how do you make it a positive experience? What does it feel like if it's working well? What does it feel like today when it was working well? What did you like? How could you transfer those sorts of experiences to NHS Citizen? So we're not asking you to write the whole plan. We're not asking you to say, well, it has to do this and this and this, and it has to talk to these people and those people. What we'd like you to do is to think as much as you can about... Oh, again, sorry. Or I just keep stepping forward, I need to step back. What we need you to do is to think about the things that you'd want to put into that mix. So tell us the feelings that you'd want to have in NHS Citizen. Tell us the routes that you think would work. Tell us the ways in which you would feel that it would show trust, or it would show that it would not have trust. And, and have those discussions on your tables. We'll move around, so if this is an unclear introduction, then come and talk to us. But pick up the conversations that you had earlier, pick up the thoughts about how NHS Citizen could work, and also think about some of the practicalities about making it really make change happen fast. Yeah, so the questions are, and they're on the board here as well. There are 2 promises to NHS Citizen: no wrong door and every issue answered. First question is, how do we make that real? Second question is, how do you make that trusted? And the third question is, and how do you make it a positive experience? Any questions on the questions? Not wishing to get too meta. Good. That means everyone's really understood the questions, and there'll be brilliant feedback at the end. Okay. And as I say, we'll be wandering around, Leslie and I, so we'll be back at 2:45. Sorry? Do feel free to move around to use the whole space, like we did in the group session earlier. We will have one full session at the end altogether, but if you want to move into there or into one of the other spaces, or now the sun's come out outside, then please do. Getting feedback from you. Now, the way I want to do this, to try to make sure that Leslie and I aren't in the centre of the conversation and people through who all information needs to pass, is I'm going to pick on a table at random and ask them to say one thing that was a reflection of their discussion, and I'm going to ask another table that talked about the same thing to put their hand up, and we'll try and kind of get the movement around the room so that you're talking to each other rather than talking to us, and we don't feel like we need to make any defence of what we're trying to do. So, I'm going to pick on a table at random, and the table I'm going to pick up at random is the one that Nadine is sitting at. So one thing that you talked about, one thing that you'd like to share with the rest of the room.
Sorry. Technology, making sure that it's not too complicated, and that recognising that some people don't use technology.
Okay, who else talked about that? Over there.
Said the same. People, not everybody has access to internet and smartphones and all these wonderful gizmos.
So, but before you give the microphone back, what do we do about that?
Didn't discuss that.
Okay, who did think about what we should do about accessibility?
I think that's the key thing, isn't it? It's looking at building on what the other table have said.
Yeah, and a point over here as well.
For accessibility, I'm sure it was a majority, that we felt that there should be one hub for access for where individuals can go or organisations can go.
One hub?
Yeah.
For a moment there, I thought you said one pub, which would also be a good idea.
Pub, hub, yeah.
Okay, something here as well.
I've got a couple of points about that particular point. We think there's a difference between those who can't participate and those who won't engage in online digital technologies, and we've got to differentiate between those two groups. But also, in terms of how people engage who are not digitally minded, for example, there are lots of opportunities in different access points. So we felt that GP surgeries or any touch point within the health service could be an opportunity. So, for example, where people are waiting, there could be those screens that, you know, like an NHS Citizen website that will be showing the actual screens, and that people can see the Twitter feeds, they can see the touch points, they can see the heat maps that are going on. So a very visual kind of activity that people can actually see as screens. But also opportunities within those particular sites. There could be opportunities given for people to feed in at those particular points as well. So it could be technologies there for the people to use.
So something that's pervasive, something that kind of is something that you can come across in all sorts of circumstances. So maybe it's still one hub, but it's a hub that is visible in lots of different places in lots of different ways. Does anyone else think about how you might be able to find your way in? Over there. Sorry, Leslie, do you want me to take over on mic running duties?
No, I like it.
More than happy.
He's got a second mic.
Goodness me, that's, luxury of two microphones. That's all right.
Hi, we talked about buddy systems and teaching people without computers, introduce them to a buddy at our PPG group, and it is starting to work. But it also socialises those older people on their own who come in, and we can fix them up with a buddy, so it has added benefits. At the moment, we're explaining and taking them through EMIS and repeat prescriptions. But we're getting there, and it's a start. So it's another direction.
One of the things that made me think of is a conversation I was listening into on one of the tables about how people can buddy up, like you were saying, but also about using a set of champions or a set of people who are willing to be the public face or be the face of NHS Citizen in their place. Now, I can see positives, I can see negatives. The positives are individuals will have some really good knowledge of their local area, but you also don't want to either overburden volunteers or create people who gatekeep and only let the issues through that they personally agree with. Did anyone think about issues around control and who was looking after issues or who was in the space? Yes, over there.
Possibly somewhat controversially, this table, I think unanimously, was of the opinion that NHS Citizen should not have a public face.
Interesting.
And
do elaborate.
that it should obtain its information and its data via organisations that already existed. For example, Healthwatch, for example, PALS, for example, all the other things. But that there should be no open door to the public because, basically, you don't have the infrastructure to support an open door, and you don't have the infrastructure to lead people by the hand from the lingerie department to the cookers department.
Okay.
And I just want to add that. Sorry, I've forgot my point now. Forgot it.
Okay. No, so I've got someone on this table who wants to come in on that.
Yeah, we sort of discussed around that very briefly, and there was mentioned of it being transparent in that, yes, it is basically a collection system. So therefore, you should go into Healthwatch or wherever, and somehow it will pick up the information. I think there has to be a sign into that, but it should be a transparent process almost. And there was another point we picked on that, which I'm just trying to remember. There was transparency. Oh yes, and it was we were moving around onto the trust on that one as well. In that, as you say, if you don't have somebody to take you from the cooker department to the laundry department, you're going to lose trust. Because if you've got this big ask of no wrong door, somebody goes in and finds there is a wrong door, you've lost the trust, you've lost them. So.
Could I just add about the public face bit? We did have a brief discussion and suggest that perhaps a public face for NHS Citizen was in its feedback to citizens. Mm-hmm. That point that was made this morning, you said we did, actually could be a very valuable public face of NHS Citizen, but to actually have people coming through a door was probably not doable.
And I think the you said we did parallels the problem with you said we didn't. Because you said we did is very common in councils, but the problem is the councils get to pick what they put on the posters. So all of the you said we didn't get ignored. I think with NHS Citizen we're trying to expose the you said we didn't. Now, sorry. Go on.
It was really, I think, that everybody on this table felt that your two promises were not just difficult, they were impossible.
Yes. Okay.
And that actually perhaps your promises needed to change, which was every voice heard and every word shared.
All right, okay, like that. Thank you very much. We'll take a note of that. We'll take a note of all of it, but that's particularly good reframing. Right, I'm going to pick on a table that hasn't said anything yet. So that table over there by the camera stand. Somebody, give us a point that hasn't been picked up yet that you discussed.
I don't know whether this is a point that's already been discussed or not, but we did tussle with this concept of it having NHS Citizen having a concrete entity and also being that filler of the grey space between all the existing organisations. And something that I spoke about in terms of my concept of it was its possibility of being almost like the canary in the coal mine. So instead of being reactive, it was, well, a canary if it dies is reactive, I suppose, but but it was finding problems before they happened. So the react teams, the crisis teams were already there, but you were alerting to them to the fact that there were issues out there. Mm-hmm. And so it was a sort of a collection device rather than a concrete entity that actually did opening and closing of doors.
Okay. Is there any other tables who talked about something along those lines they'd want to kind of add into that part of the conversation? So I think one of the... No, go on. Sally.
It's just talking
Microphone, sorry.
Talking about your risk and being more reactive or proactive, and actually getting in touch with those teams who actually deal with those issues. One of the things, and I wasn't something I discussed at the table, but in terms of who they link into, that the CCGs already have their patient safety and quality teams, and they are the natural home to be recipients of information of that nature.
Going back to the John Lewis analogy and just some of the things that have been said, is that the way to make like this, any of those two promises, I agree, are pretty hefty. But if you haven't got the right people answering any wrong door, if you haven't got the right people listening, who are well trained, who are empowered, and actually give them monkeys, none of this is going to work. So a big, I think we've got a respiratory of teams here from various different organisations, and we do what we believe to be a good job, and some teams who might be represented or otherwise will do a better or worse job. But if you haven't got those right people who want to do something, want to make it better, then the public can talk to the cows come home. Nothing's going to happen. So one thing that we talked about was the responsibility to get the right people to talk to and the right people to make the actions.
Okay. Really important point about the culture, which I don't want to lose in these next comments, but we'll come back to.
I would just follows on from that, really. As well as having the right people, they need to have clarity about what constitutes an answer. We felt that not being able to answer was not an acceptable answer. And that if you continue to provide an answer over many years, then it will be a positive experience.
Yeah. I was going to say on that table as well, Scarlett was giving a really good story about patient opinion and how she had a very positive experience with patient opinion in terms of building people's trust. So I don't know whether you'd like to share that. Feel free not to.
Yeah, I was just giving the example that we subscribe to patient opinion, and we recently had someone who's left a story about her experience of going to A&E, and in that story she'd experienced NHS 111, she'd experienced Devon Doctors, and because we subscribe to that, we're alerted of these stories. And as a CCG, we responded to her story. Devon Doctors responded to her story, and SWAS responded to her story. And she'd made a point about how the posters in A&E were really out of date, and the information wasn't right. And what had happened is Devon Doctors had responded and said that they were going to make a change. And what happens on patient opinion is they actually track the changes, and that story comes up with a little green sort of button, and it shows that changes have been made. So the patient then has reassurance and has a positive experience because they can see that we have actually made changes as a result of the story that they have left.
Thank you. I think there was one other comment on that table I don't want to lose. Sorry. Do you want to say something as well?
Just picking up on Sarah. I'm actually a PALS manager, so I'm used to dealing with things immediately and getting things sorted. And part of what we hear so often is somebody saying, I'm glad I'm speaking to somebody, and for them to go away feeling that they have been heard. But then it's about delivering on your promise. So if you say, I'm going to phone you back with an answer by such and such a time, making sure that I do that. If I can't come up with the answer at that time, still phoning them back when I say I would to say, this is where I've got with it. This is why I haven't been able to finish it, because this is what I'd like to do. Is that okay with you? And taking them forward as a partner in getting to the solution, but keeping them informed so that I'm delivering on the promise that I've made. And that helps to build that trustworthiness, because then they'll come back later on. You helped me before. Can you help me again? Because I've got another issue with another organisation, but can you sort it because you delivered?
Yeah. Thank you.
It's kind of on what you brought up about what is an answer, and I'm speaking from a Health Watch perspective, and I would hope that an answer would be meaningful, but if it wasn't, then Healthwatch itself has powers to compel commissioners to answer in a meaningful way. So I think that is something that Healthwatch could bring as a bit of confidence to people who are involved in PPI who might have a particular issue. If they felt they weren't being answered, actually Healthwatch has got Section 221 powers to request a meaningful response within a period of time, which you'd hope you wouldn't want to invoke that, but it is there. So maybe those kinds of standards need to be looked at when trying to solve the solution about what is a meaningful answer.
Okay. Yeah, we discussed quite a similar thing to that, about honesty and what's realistic, but it's getting that feedback, isn't it? So like what Jenny said, having a response, and even if it's not an answer, it shows that something is being done. So it's honesty to say that you cannot do it at this time, but we are looking into it.
Do you expect a timescale around
Yeah, timely as well, definitely. Yeah, that's what we also discussed. Yeah.
I think delivering on that goes back to the culture point, the culture and attitude point. Did anyone else pick up on issues around culture, attitude, the way in which people need to behave, as well as the things that people actually have to do?
Yeah, we did in trying to answer question one. How do you achieve your general overall thing? And we both felt that there needs to be a major investment in the training of staff who believe in the concept, and that's going to require budget. I mean, I don't work in the NHS at the moment, but I am aware that there's been a lot of reorganisation and a lot of money put into reorganisation, but then not a lot of money to back up the retraining that's needed to get people to do it. So for you to go forward, the government is going to have to support the project by you getting people who are on side with and believe in what you're doing and train them so that they can deliver against your set of targets. And keep repeating that, and keep repeating it, and don't change it, and don't change the name in 5 years, and keep going at it, and keep going at it. And then you might get back to where the level of trust that the NHS has had.
Okay, that's great. Really important point. Thank you very much. Now, we've got about 4 or 5 minutes left in this part of the agenda. So is there anything else that people picked up on tables that we haven't talked about yet, that you feel needs to be shared with the room?
Can I ask a question?
Of course.
We have Healthwatch Cornwall, Devon, Somerset, etc., which feeds into Healthwatch England. Can you explain the difference between Healthwatch England and Citizens NHS England? Are they going to be the same with a different name?
No. So just to kind of go back to some of the things that we were talking about this morning, briefly, the NHS Citizen piece of work is not about creating a consumer body. Healthwatch England is a consumer body that deals with patient experience and deals with what's happening with patients. NHS Citizen is much more about the accountability for NHS England and the decisions it takes, but also giving the NHS England board the ability to see what the public conversation is about the health service and to take strategic decisions in a more informed way, with citizen participation more in the centre of the NHS. Whereas Healthwatch England is about coordinating the activities of local consumer champions around the health service in England. So people are both citizens and consumers, but we're talking here about their role as citizens and as stakeholders of the NHS, rather than necessarily their role as patients and consumers. Does that make sense? We can pick it up after maybe, because I want to make sure that we're getting all of the last points. But thank you for that contribution. I'm happy to talk about it afterwards. Yes.
You've just said that that NHS Citizen wishes to put citizens at the centre of the decision of the strategic decision-making process, or words to that effect.
Tom.
How do you choose those citizens? How do you make sure that they are representative? And this is where I still cannot see, I'm sorry, even at the end of today, I cannot see how this system is going to work.
Okay, I think I think we need to pick up all of the points. The answer to the question, how do you make them representative, is it's not a jury. The NHS Citizen is not trying to make decisions. is trying to gather as many voices as possible so that people who do make decisions, which will always be the NHS board or NHS commissioning managers, have the biggest set of public views and public information to work on. You know, it's not a decision-making body, and I think it's a really important point to make. But I want to leave it at that so we can get as many views in as possible.
Anthony, can I just add just one quick comment in response to that? Just to say that the way that the Assembly meeting could be constructed is going to be one of the issues that we discuss at our next workshop, which is going to be in Leeds in May, 7th and 8th of May, I think I'm right in saying.
Mm-hmm. Yep.
So, by all means, if you can sign up to attend or beam in through the internet, because that's one of the issues we'll be discussing there. So it's a very important issue that we'll be picking up at that workshop.
Yeah, thanks, Cliff.
There was just one small thing that hasn't been mentioned. Whichever way you go, make sure that you're building sufficient time to test and before you deliver.
Yeah, completely agree with that. Absolutely. I'm going to...
Anthony, can I just make one more?
Yeah.
Just picking up on Clive's point. I appreciate Leeds is a really long way from here. I know I've got to go back there and a bit further tonight. But if you want to email us any comments, particularly around the Assembly bit, and email us in any ideas around this whole issue about representativeness, I'm really interested in unpacking that and what people think about it. So please don't think this is the end of your involvement, because we know where you live. You told us.
Yeah. Okay, Leslie?
I'm struck. If you remember, earlier there was a question that said, what's NHS England for? And Olivia gave a very thorough response, part of which was saying that NHS England is a leader for the system and also has a role at looking at strategic and policy issues. And I'm struck by the conversations that we've heard about so far have all been around discrete, fixable issues where people can feedback. And if you remember this morning when Catherine was talking, she said one of the challenges is holding the complexity of two very distinct but interrelated things. And I think one of them that we haven't talked about yet, which links with your question about what we haven't discussed in the room, is what do we talk about, the big change issue about what is going to be the NHS for the future, which isn't going to be fixable with an answer that you can give straight away when somebody starts to engage with, but is going to be a longer-term deliberative process where we're all going to have to work out how to hold the complexity of exploring and discovering an answer together. And I think that's something that we need to hold in mind for the work of NHS Citizen.
Okay, thank you very much, Leslie. Now, there's two more small things to finish off today. The first is just to pick up on broader things that are things that people feel they would like to say. Olivia is going to just quickly wrap up with her reflections on the day, and also talk a little bit about what happens next. Just before we do that, I would like to say that this is something that is a developing process. So do keep an eye on the emails, the website, the paper newsletters that you receive. You will see more, and the next time you see it, it will be different. And the time after that, it will be different. Because this is a process that's developing and won't finish developing for some time. So that's my kind of thought, but I'll hand over to Leslie to pick up any final reflections before Olivia closes us down. In the nicest possible way.
Brings us to a happy ending.
Takes us out.
There is going to be a happy ending, and it will be me singing. So I'm going to do it. When we're looking at human relations, one of the things that shapes a communication between two people is not just what is said, it's what's not said, and it's what's hard to say, and it's the things that aren't said that you don't know that they're not being said. So there's all of that stuff going on in the background behind these very nice communications that we've been having today. So for the two things that we can access, i.e. what you've not said that you'd like to say, but has been hard to say, or that what you've not said that's quite difficult, now's a chance. Because this is a co-design. You are all co-creators of this NHS Citizen model, and your constructive criticisms and your downbeat feelings are also useful data for the further development work that we need to do. So let's hear it. Nothing is unwelcome, but be as succinct as you can.
Two ex-NHS employees sitting on this table who both agreed that we'll listen to people who clearly believe in this project going forward, But we felt it was very difficult for us to be open and honest with you about how difficult we think that it's going to be for you. Because we've worked in the NHS, because we understand how difficult it is for you to take it forward. We're quite cynical. We hope, upon hope, because we love the NHS, that you will be a silver bullet, and that it will be fired at the right place and that it will fix everything. But we have to say that we had our doubts, didn't we?
Okay. We are the gun, you are the bullets.
There's too many words and not enough diagrams in your documentation.
Okay. I just...
Too many words, not enough diagrams.
An easy read version is coming for the 7th of May.
But I don't mean easy read, I just mean by...
But I mean, like, with more kind of diagrams and things like that. Yeah. Fair point. We are naturally wordy people. I'm sure you can't tell.
I think there are a lot of professionals here today that are possibly struggling with the concept of NHS Citizen, and I wonder how Joe Public will be able to understand it if the people in here are also struggling.
Sorry, I've got it.
Is there NHS Citizen Wales? And if not, why not?
Because NHS England covers England. And if NHS Wales wanted to copy or parallel or use the same tools, I'm sure it would be an option for them. But, you know, it's...
Wales calls, we will answer.
If Wales calls, if Scotland calls, if France calls, we're always there. But at the moment, we're working in England.
Anybody else?
Regarding previous remark on I'm a lay person, I'm very involved in the NHS. I've been struggling for 4.5 years, banging on lots of brick walls. I've been disappointed so many times, especially on representations I've made for other patients. I just hope it is also a silver bullet. But I will add that I don't believe in silver bullets. It's just hard work that gets you there.
Yeah, I think that's certainly true. Okay.
Malcolm.
I've already expressed my lack of understanding, for want of a better word. That's not quite true. I'm not an NHS employee. I'm heavily involved with health, and I've got pretty good knowledge of the NHS and the way it works. But I'm sorry, I cannot honestly see the place for this organisation. And if I can't see the place for this organisation, I really cannot see how Joe Public is going to relate to it. And it would be very interesting to know on a straw poll just how many people in this room now, at the end of the day, thought the same as I do, that Joe Public would not relate to it.
Yeah.
Okay, I've got an issue as well about talking about the different spaces and about if something comes up for a conversation and taking it forward, that might reflect on having to have a level of numbers and that there might be issues which relate to just a few people, but which are absolutely vital. I'll give an example of gender dysphoria, because Devon has one of the few centres in the country. Not many people affected, but would they still have a route to have their voices heard through this model in some way to get some changes, particularly since NHS England and Specialist Commissioning are changing the goalposts as we speak and causing all sorts of different issues to happen, and how we can have those dialogues as well without losing the fact of one voice can be significant as well as the many.
I think it's a really important point. It needs to be significance, not numbers.
Absolutely, and I think that was the point that we were trying to demonstrate earlier when we were doing the reflection on the morning's work, is that every voice matters and every experience matters, and it's really hard for us to stay in our own heads. So the point that Malcolm was making about Joe Public, and we've made lots of comments earlier, heard a conversation earlier about the usual suspects. There is a real tension for us to stay in what do I know, what do I think, what do I feel, and not to project that onto other people. So earlier this morning when we were struggling, it was Joe Public who brought into the room a very live understanding of what we were trying to do today. So I don't buy the story that Joe Public won't get it because all the professionals won't get it. Often it's the professionals who've got the most work to do, as we heard earlier that people don't give a monkeys because they're stuck in playing the power games in their journey up the hierarchies. We've got some work to do to ensure that the people who are paid to do the work to serve the public can do that as best they can and not think for the public. And I think that's part of our challenge in NHS Citizen, is to be ready to hear. And so what can be construed as an impossible task actually might just be the thing that will flip this whole thing on its head. And we'll discover that it's not impossible because maybe we can hear everybody and aspire to be able to move people through the system through committed and passionate workers working with able, skilled people in all sorts of ways.
One more comment, and then Olivia, I think we'll need to wrap up if we're going to make our promised finish time.
I just wanted to, talking as a professional, I completely agree with the spirit of this exercise. And I think a lot of people agree, whether we're Health Watcher or whoever, we agree with the spirit, and I think I don't think anybody comes into the health service not really caring, because you have to work quite hard to stay and be successful in the health service. But my reservation is that this model will not look like this in 5 years' time. And I think maybe that's what's confusing, is that what we perceive is great, the repository of the bank of information, great, thumbs up, wonderful. But I don't think it's going to look like this at all.
Cool. How do I sum all that up? I never cease to be amazed about how getting a room full of people flushes out more and more new ideas, views, thoughts, and expressions of conversations we think we've already had. So we've had these conversations for the last 6-7 months, and yet today we've still flushed out things. So that the self-care point that came up this morning hasn't come up in these conversations before, and yet it's hugely important. And I'm kind of thinking, why has that not come up before? And I need to go away and think about that, because I think that's really important. Just to pick up on a few of those final reflections, we've defaulted to thinking about this thing as an organisation again. And I just want to reinforce, this isn't about an organisation. We've talked about having the right people with the right skills, that there are training issues, it's about how we respond to things. For me, this is about constructing a way of thinking about how we really hear, involve and engage people's voices and people's experiences in a way that has impact and makes a difference. And that's about working together. And it's all of these voices. They shouldn't be competing. So this isn't an either or, it's a both and. So, and I do want to reinforce, we're not trying to create an organisation. We're really not. So please, if it ends up as an organisation, I've said this before, I'll walk away from it because it's probably going to be the wrong thing. Picking up on the transgender work, so one of the first actions we took, or my team took, is we've been undertaking a national engagement exercise around what the transgender issues are in terms of the gender identity clinic, so working very closely with John Dean, who's the lead and chair of the clinical reference group, which again has been a really interesting journey and experience of taking and working with a community who have absolutely no trust at all in the NHS, in the services that are there designed to support them because of the stigma and experiences that they've had from the clinicians and from the commissioners. So we've brought all three groupings together through a series of workshops and held conversations a bit like this. And actually getting people to talk those experiences through has started to build trust. So just the simple act of bringing people into a space together to have those conversations together which has never happened before, which I find quite shocking, has started to rebuild some trust and started to make change in terms of the way that the service specifications that NHS England commissions against are delivered. That's quite a journey, and that to me is a little expression, but a really significant one, of what this NHS Citizen journey might look like. But it's just one, so I'm really pleased you raised that. The one quote I'm going to take away is the every voice heard, every view shared. I think that's brilliant. And I was sitting talking about some of these questions, thinking actually, is it every issue answered? Because we don't have the answers to every issue. But is it about how do we co-create some solutions together? So having the answers feels a bit still them and us. And I'm not sure this is them and us, because I don't think that there is answers to everything. I think there's an awful lot of answers that we need to find out together. So I'd want to come back about whether or not that is the right question. And this is a bloody hard concept. It's a really difficult thing. If participation, PPI, whatever we've called it, had worked, would we be where we are now? Why have CHCs gone from that to PPI forums, to links, to Health Watch? Are they really making a difference? Is this what we've got to challenge, which is actually about the behaviours and the attitudes of staff in terms of their willingness to engage with people's voices? Is it the structure that's wrong, or is it the people who are willing to engage in that to make a difference? And I don't know is the answer, but I think we have to explore some of that together. And cynicism. Can you please keep being cynical? I don't think this is a silver bullet, but without the cynicism and the challenge, we won't develop something that actually works and has impact. And that's all I want to say. And I want to say a massive thank you for giving us a day of your time and for some brilliant conversations. So please do keep following it. Anthony's writing a blog that will be up tonight because he's got nothing better to do this evening.
Because I'm on a 3-hour train journey back to London from Exeter Central, yeah.
So please keep an eye on the NHS Citizen website. Keep in touch. If you don't tweet, join Twitter. It's quite good fun. If you don't want to join Twitter, keep in touch via the website, via email, via whatever means. If you want to send me a letter, I love opening letters. That's great. But please stay involved and keep being cynical, keep challenging us. But please try and help create something that will work. Thank you.
Number two. And just a big thank you to you all. Give yourselves a round of applause and give Susie and Marella a round of applause for keeping all the words up. And our technical team at the back and the people at home, we love you and we miss you. And now for my song.